diabetes who have depression. So depression is associated with all stages of the diabetic continuum. So more incidence of pre-diabetes, more incidence of diabetes, more incidence of suboptimal glycemic control, complications, and mortality. Now, if you see the common mechanisms for depression diabetes link, then diabetes-related distress is very common, which we all know very little about. Depression, in a way, is more common. Impulse control is also disturbed, and satiety is also disturbed in diabetic patients. The type 1 diabetes, diabetic patients have more incidence of bulimia, especially the ladies, and type 2 are more towards eating more and more. Now, the biological processes which connect the depression diabetes link are the disturbed HPA axis, the pro-inflammatory states, the autonomic nervous system disturbances, early life programming, antidepressants, circadian clock, gut hormones and satiety, sleep apnea, and mitochondrial disorders. So this is reflected well in this diagram. If you see both diabetes and depression, there is a common soil hypothesis. The genes, the fetal nutrition, the 50 gene hypothesis, where the because of the malnutrition in the fetal period, the baby is basically having less proteins, more fats, and his propensity to eat more after in the early years of life, in the later years of life. Then the lifestyle disorders, the social adversity, all of this combine basically to lead to more incidence of diabetes and depression. And depression is more common in type 2 diabetes. Depression associated with increased mortality, and treating depression alone does not improve glycemic control. So basically, if you want to have a good glycemic control, then you will treat diabetes as well as the depression. Both things have to be treated to have a optimal control of diabetes. Both depression and diabetes associated with high risk for all cause dementia. So dementia, as it is more common in diabetes, and add-on depression. So depression and diabetes will lead to even more incidence of dementia. Associated hazard of all-cause dementia 31% higher, a decrease in subsequent years, and as the duration of diabetes increases, the hazard ratio increases, and the incidence of dementia increases. Both depression and diabetes associated high risk for all-cause depression. This depression diabetes can cause dementia. The dementia may be pure dementia, or maybe Alzheimer's dementia, maybe vascular dementia. So all sorts of dementias are increased in patients of diabetes with depression. So dementia basically affects 6 to 10% of people 65 years or older, and rates increase with age. Depression is 1 to 5% of older adults. Depression is common in dementia. Almost 20 to 40% of the patients with dementia have depression. Diabetes and depression exhibit a closely linked bi-directional relationship, as we already seen in the earlier diagram. Depression is 2 to 3 times more common among diabetes compared to without. Comorbid depression and diabetes have 2.7-fold increased risk of dementia. So you can see that all these diabetes, dementia, and depression, all these are closely knit together, and one leads to increased chances of other missing. So they are going hand in hand, and the more if we have only depression, then diabetes will be more, and if you have even dementia, so everything keep on increasing as the odds go up and the duration of diabetes goes up. Now, bidirectional link between depression and diabetes, this has been found in the studies which have been plotted here, and it is said that baseline depression predicts the incidence of high incidence of diabetes, especially type 2 diabetes, and baseline diabetes predicts the increased incidence of depression. So depression doubles subsequent all-cause dementia risk. A history of depression may confer an increased risk for later development of Alzheimer's disease. This relation may reflect an independent risk factor for the disease. Interval between diagnosis of depression and Alzheimer's disease was positively related to increased risk of developing Alzheimer's disease, suggesting that depression may be a risk factor for Alzheimer's disease. Meta-analytic evaluation resulted in pooled odds ratio of 2.03. So both depression and dementia and diabetes are very, very positively correlated with each other, and each increases the incidence of or prevalence of other. The obstacles to recognizing depression in medically ill patients. Now, what happens is that a chronic patient of diabetes with neuropathy, with other comorbidities, if he complains of something, then everything is attributed, you have diabetes, it is related to diabetes. So nobody goes in depth to evaluate his symptoms. Suppose they lost weight. it is because of diabetes, you are not having diabetes in control, low appetite, acute diabetes, poor concentration. So all this basically, so it is imperative that the healthcare professionals and healthcare providers be educated about the incidence of diabetic distress and the mental disorders in diabetes, which border to eating disorders, anxiety, and depression. And we should have proper questionnaires in place, basically, which patients have to fill while they are waiting in OPD, so that we can detect these conditions. And these conditions have to be detected early in the diagnosis of diabetes. And am I audible?
Yes, sir. Audible.
Okay. Now, obstacles to recognizing depression medically, we have seen what are the obstacles. Now, if you see the this study, total 372 patients, of them basically 23 not diagnosed with depression, although they had depression. Two eight diagnosed with depression. Then we have several patients who are not diagnosed with depression, but they have high somatization score. And then the green will depict those who are diagnosed with depression. So if you see the overall parameters, only 11% had major depressive disorders, and although only 2% were recognized. So you can see that very less of these patients of diabetes are detected with dementia, sorry, with depression, and we have to be very, very keenly on alert to detect these cases. Why these are not detected? Because a lot of these have somatic complaints. There is somatization of the complaints, and these complaints may be chest pain, maybe retrostal burning, maybe tachycardia, irregular heartbeats, neurological like complaints, like patient may be having headache, or patient may be having tingling or numbness, dizziness, syncope, seizures, gastrointestinal complaints, epigastric pain, diarrhea, pulmonary dyspnea, asthma. So all these complaints basically will lead the healthcare provider to think on the lines of the particular system of which is pertaining to the specific complaint. They will investigate that system, but they will not look into the fact that this may be related to a psychology associated with diabetes, which will be either diabetic distress or which will be depression. So we have to be aware of these things, basically, if we are to diagnose these conditions. Now, depression predisposes to diabetes. There is a 37 to 100% increase in type 2 diabetes, independent of obesity, activity levels, smoking, alcohol consumption, and family history diabetes. So, pre-morbid depression is an independent risk factor for development of diabetes. In type 2 diabetes, generally the psychological disorders predate the age of onset of diabetes. In type 1 diabetes, generally they follow or appear after the type 1 diabetes, they appear in the later stages. Now, depression versus the diabetes morbidity, like cold hands and feet, numbness of hands, feet, pain in hands and feet, abnormal thirst, blurred vision, detached sleepiness, all these complaints are much more if the depression is associated with diabetes. And you may interpret as diabetic neuropathy, even if you control diabetes well, give proper treatment of neuropathy or the condition which you think, still the complaints will be much more, they will not abate, and you have to diagnose this condition if you are to get this patient in control and get him into comfortable shape. Now, depression as a contributor to diabetic morbidity and mortality, it leads to poorer glycemic control, increased risk of diabetes-related complications associated with more incidence of retinopathy, nephropathy, microvascular complications, and sexual dysfunction. Coronary heart disease more rapid in depressed women, lower quality of life in these patients. Depression as a contributor to diabetic morbidity and mortality, higher healthcare costs, symptom amplification occurs if depression is associated with diabetes. Depression may have worse course among diabetics. Relapse rate is 5 times higher than in non-diabetes. So both of these conditions will lead to worse outcome in the treatment of either of the conditions. So both have to be treated simultaneously to have a good result. Now, depression worsens the diabetic mortality. If you can see that if there is a diabetes, then the all-cause mortality increases. But if diabetes and depression, then the all-cause mortality is even worse, basically. So, they both are independent risk factors for all-cause mortality. So what happens is depression, it leads to lack of motivation, poor management of diabetes, high blood sugar levels, greater fatigue and lethargy, and worse mood, which again leads to more depression. So this is a vicious cycle which goes on and on. If you see the relation of glycosylated HB and cognitive decline, when the atherosclerotic risk in communities, that is the ERIC study basically, it was inferred that HbA1c was not a significant independent predictor of cognitive decline while stratifying by diabetes diagnosis. So, which suggests that you have to go for a multifactorial treatment. You have to treat all the associated morbidities if you are to get a good control of the dementia part, the depression part, and here the blood pressure control, better control of diabetes, avoidance of hypoglycemia, very important, statins, treatment depression, and emphasis on early cognitive function assessment and its management. All of these have to go hand in hand if you have to have a good prognosis in these patients. Now, does treatment of diabetes make a difference? Prospective study of type 2 diabetes and cognitive decline in women, that is the nurses study conducted between women 70 to 81 years of age. It was found that those women who have well-controlled diabetes with oral hypoglycemia have a similar incidence of depression as non-diabetics, but those women which are not using medications who had uncontrolled diabetes had greatest odds of poor performance. Women with type 2 diabetes have a 30% greater odds of poor cognitive function than those without diabetes, with 50% increase after 15 years of diabetes. So duration diabetes is also a important aspect here as far as development of dementia, which is understood because as the duration goes up, then the vascular damage, especially the small vasculature gets affected, the blood supply gets affected, there are multiple small infarctions in the brain, and that is a separate risk factor for dementia. Now, hypoglycemia is one of the most important things to early onset of dementia. So hypoglycemia has to be higher HbA1c in the population, even less HbA1c up to 8 also or 8.5 also, if, but you have to somehow get rid of hypoglycemia. Now, individualizing HbA1c goals, user HbA1c targets are generally less than 7, but if there is dementia, then you can aim for even HbA1c goal of 8.1 to 9, especially if the life expectancy of the patient is short. Because if you have episodes of hypoglycemia, you may have basically significant cognitive impairment, hypoglycemia unawareness, history of falls, evidence of advanced poorly controlled cardiovascular or microcephaly. You can realize the goal to diabetic management. Now, adverse effects of dementia diagnosis on management of diabetes. So you can see very well that dementia reduces the likelihood that individual with diabetes will receive recommended usual monitoring for diabetes mellitus. So basically, dementia basically is a obstacle for optimum control of diabetes and optimal visits and optimal follow-up by the diabetic healthcare providers. So dementia has to be tackled in the root and it is better avoided. Now, why we should care about diabetes and the mental disorders? Because psychosocial issues can have a big impact on quality of life, self-care behavior, and glycemic control. And as we've seen that anxiety, depression, eating disorders, and diabetic distress are the four common varieties of psychological comorbidities associated with diabetes. Now, depression, we have already seen that almost 25 to 40% of the patients with diabetes will get into depression depending on the various factors. Anxiety is pretty common. The lifetime prevalence of generalized anxiety disorder is almost close to 20%. And then there can be other anxiety disorders like the obsessive compulsive disorder, specific phobias, post-traumatic stress, and it is more common in patients with diabetes. Eating disorders are more common, as we've seen, bulimia more common in type 1 and binge eating more common in type 2. Now, ADA, psychosocial position statement, we have already discussed in 2016. Everything was discussed and guidelines were framed. Now, diabetic distress is a common undertreated emotional state, is a practical approach to diagnosis and treating psychological comorbidities of diabetes has been framed by the ADA 2016 guidelines. Diabetic distress refers to an emotional state where people experiencing feelings such as stress, guilt, or denial that arise from living with diabetes and the burden of self-management. Then a state comes when the patient grows tired of managing their disease and simply ignores his disease for a period of time, or worse, he may ignore it forever, and we call it diabetes burnout. Diabetic distress has been linked to worse health outcome. The difference with diabetic distress and depression is that diabetic distress has to be managed right at the healthcare provider's place rather than being referred to psychiatrist. It has to be referred to psychiatrist only in specific states. Otherwise, we have to manage, we have to recognize and manage it at our own clinic basically to have optimal results, because if you don't recognize and manage it, the control of diabetes will not be that good. Now, the prevalence of diabetic distress, overall prevalence of diabetic distress noted in meta-analysis of 55 studies was found to be 36%, and a higher prevalence was seen in denial, loneliness, low motivation, frustration, fear, and this all emanates from fear of experiencing hypoglycemia, fear of experiencing long-term diabetic complications, interconnectedness of blood glucose levels, and mood, behavior, well-being. And type 1 regimens may be also very stiff, basically, like multiple injectable therapy, fear of injections, fear of hypoglycemia caused by the injections, type 1 diabetes related emotional and physical burden, interpersonal and social stress. Supportive and therapeutic environment, including family, healthcare professional services, peer support group, will help in decreasing the diabetic distress. Now, diabetic distress can occur at around the time of diagnosis of diabetes, around the time of learning how to self-manage diabetes, because they feel that this is a big issue. Basically, they will not be emergence of any complication like the patient related to have retinopathy or nephropathy. At the time of switching medications and healthcare plans, like patient from being switched from oral medication to time of switching healthcare providers, that all these points of distress, and the major symptoms are the major symptoms are feeling unmotivated, hopelessness, overwhelm, frustration. So all these symptoms are basically there you can see, and it is basically related to the various aspects of diabetes, the perception of various complications and treatments of diabetes, and the perceptions of complications, or the patient already has got into complications and he's feeling very distressed about it. So all these will lead to increased chances of diabetic distress. Now, depression and distress, you have to differentiate between depression and diabetic distress. Now, depression or major depressive disorder is complex and debilitating condition and frequently coexists with diabetes mellitus. Prevalence of depressive disorder is basically approximately 3 times higher in patients with type 1 diabetes than in general population, and twice as higher in type 2 diabetes. Patients with diabetes mellitus and major depressive disorders have poor health outcomes and high mortality states. Now, diabetic distress is not as the same as clinical depression, and unlike depression, diabetic distress is persistent over time, associated with glycemic control and disease management issues, expressed in terms of magnitude and content of the distress. Diabetic distress sometimes coexist. However, it is important to differentiate and treat them accordingly. And basically, you can differentiate both of them with the appropriate questionnaire. Basically, give the questionnaire to the patient, the patient fills up the questionnaire, and you can very well know that this is a depression and this is a distress. Like a patient, if he has suicidal tendency or if he has a paranoid ideas, then you can say that this is more of a psychological issue than the distress part. Basically, distress part is not that severe. It is more of a perception disorder, more of anxiety disorder, which you can control with the help of your counseling, basically. So these are the differentiating points. I will not go into much detail of both of these, but with the appropriate questionnaire, basically, you can differentiate very well whether it is a depression or whether diabetic distress. And when it is a depression or a major depression, then patient is better referred to psychiatrist. Where it is a diabetic distress only, you can manage the patient at your level, basically, and try to get help only if you're not able to self-manage. Now, this diabetic distress may arise anytime, so we have to be very vigilant. We have to periodically administer the questionnaires to the patients who are coming to our OPD, and the healthcare provider or your staff should be trained to identify the distress part and to take care of it immediately. Management of diabetes stress is screening and diagnosis. First, motivational enhancement strategies have the potential to augment patients' own motivation to engage in health behaviors. Second, behavioral modification principles can increase patients' self-regulation and their experience of success. Third, managing diabetic distress emotions, including anxiety, depression, and distress, specifically relates to diabetic care and fear of hypoglycemia. And coming to the last part, we have a 7A approach to manage the diabetic distress. You have to aware, you have to ask your patients, you have to assess your patients by using various tools. You have to advise your patients, you have to assist your patient, you have to assign or refer the patient if you are not able to handle your patient well, and you have to arrange follow-up. So, with this strategy, we manage our patients with diabetes stress. So with this, I will like to end my lecture. I thank the Lupin team for providing me the opportunity to share this specific aspect on the under-discussed aspect of diabetes with you all. Thank you very much.
Thank you, sir. Thank you, Dr. Singh, for your elaborate and very efficient and elusive discussion regarding the diabetes and its aspect on mental health. Now we have another important topic from the psychiatry perspective that is been discussed by Dr. Sandip Shah, sir. So over to you, sir.
Good evening, everyone. And first of all, I would like to thank Lupin Cross Connect for giving me this opportunity. Of course, because Dr. Akash, my good friend, recommended my name. I'm thankful to you also. I have no conflict of interest to declare. And yes, this is a very important topic where I would like, and I'm very happy to talk about diabetes and psychiatry. In fact, not only depression, but many of the psychiatric disorders, they would definitely be very important when we are treating anything which involves managing the lifestyle. And diabetes definitely is a very important disorder where lifestyle plays a major role. Mental illnesses in psychiatry, there are conditions when patients find it difficult to understand the lifestyle, to follow certain uh, norms, why these are important, and therefore compliance issues will be a major issue when a person is having diabetes and also a mental health related problem. Now, there are certain conflicting informations also and certain uh, findings which accelerate or which are synergistic with existence of one and the other. So, present as co-occurring independent conditions with no apparent direct connection in few of the studies, diabetes and depression. However, diabetes also has a risk factor for development of psychiatric disorders. Psychiatric disorders as risk factors for emergence of diabetes, overlapping clinical presentation of diabetes and psychiatric disorders, interaction of medications, which are very important nowadays, and impaired treatment adherence, as I told. Compliance with medication is one of the major issues where we find it difficult to handle. The implications of co-occurring diabetes and psychiatric conditions, as some of these has also been covered earlier, impaired quality of life, increased cost of care because twofold or even higher depending on the treatment setting than the population without co-occurring psychiatric disorders, poor treatment adherence, poor glycemic control, increased emergency room visits due to diabetic ketoacidosis, higher frequency of hospitalization, higher rate of absenteeism at work, and all this also will add to the cost of treatment. I would like to cover a couple of the disorders, especially mood disorders, anxiety disorders. I would touch upon psychotic disorders, schizophrenia, and the medication and how it is important when we are treating diabetes and these mental illnesses. So, mood disorders, as you all know, majorly it's a bipolar disorder and major depressive disorder. These are the common mood disorders which we like to talk about. Co-occurrence of diabetes and depression has been established in clinical as well as general population studies, and this co-occurrence is associated with increased impairment as well as mortality. Risk of developing depression is 50 to 100% higher among patients with diabetes compared to that among general population. Prevalence of diabetes among bipolar disorders has been found to be increased or equal to that observed in general population. So the highlight is that you can see more of the influence of diabetes on major depressive disorders than on bipolar affective disorders. Emergence of depression and diabetes is associated with increased complications, mortality rates, and healthcare costs. In my own experience, I have seen patients coming to me with extreme anxiety and suicidal ideation once they are first time diagnosed with diabetes, and they just feel how they are going to live through this. And this is something terrible which has happened, and a lot of counseling plays an important role. Talking of depression, one of the most commonly occurring mental health condition nowadays. Currently, about 7 to 8% of general population suffer from depression. Indian studies have gone to report up to 35 to 40% of general population incidences of depression. One of the most easy to diagnose mental health condition. Most of the time, depression goes undiagnosed because of the attitude of the physicians or the clinicians or the family practitioners who have less time or who find it difficult to give time to the patient, which is a pursued limitation of time. In fact, couple of questions, if they are asked to the patient, just two questions: how are you feeling? Are you feeling low? And are you feeling depressed in last 15 days? And if there is a yes to it, then only a in-depth interview may be required to diagnose depression. So if treated timely, can lead to multifaceted positive impact of quality of life of a mentally ill person. If treated timely, will lead to preventing a majority of suicides, which are secondary to depression. And what is required to diagnose, as I told you, is only a few right questions. Diagnosing psychiatric disorders among patients with diabetes, up to 45% of cases of mental disorder and severe psychological distress go undetected among patients being treated for diabetes. Due to patient and physician related factors, these disorders go undetected. So if we can use simple scales like the PHQ-9, the symptom checklist 90, the heads like patient health questionnaire or hospital anxiety and depression scale, we routinely evaluate for pain and psychological distress. And then we can optimize treatment for better control and quality of life. Why is diabetes depressogenic? Because of the biochemical changes, like including neuroendocrine changes such as hypercortisolemia, leptin activity in limbic system, altered glucose transportation, pro-inflammatory cytokines associated with diabetes or its treatment, psychological factors such as distress or stress associated with living with diabetes, poor treatment adherence, and behavioral factors like sedentary lifestyle, smoking, overeating, or substance use have been implicated in this causal relationship. Amongst anxiety disorders, generalized anxiety disorder consistently increased risk and confounders of panic attacks and hypoglycemia. If you see in this forest plot, depression as a risk factor for onset of type 2 diabetes, you can see that in this forest plot, most of the things are above 1 and therefore they are significant. So if you see that there should be a diamond below the 1 here, and above 1 means they are significant. So the pooled relative risk is at 95% confidence interval was 1.26 using fixed effects model and 1.37 using the random effects model. You can see here the depression affects negatively the glycemic control. If you compare of unadjusted mean HbA1c over time among depressed and non-depressed adults with diabetes, you can see that the red line or the orange line, which shows depressed population with persistently uncontrolled or poorly controlled HbA1c, compared to the blue line of non-depressed diabetic patients. Now, another important issue is choosing an antidepressant. Special considerations for diabetics. The currently most commonly used antidepressants are the SSRIs. And yes, use of SSRI has also added to improved glucose control, reduced insulin requirements among type 2 diabetics, maybe because of proper compliance and adherence. The MAOIs or the monoamine oxidase inhibitors, which were not available in India so far, now we have phenylcypromine, but it is associated with hypoglycemia, orthostasis, dietary restrictions, medication interactions, and restrictions. So it's not a very popular drug. Tricyclic antidepressants definitely have issues when they are being used in comorbid diabetic conditions, especially weight gain, increased glucose, cardiac conduction delay. However, most of the tricyclic antidepressants are used in treating diabetic neuropathy in a lower dose. Depression treatment improves insulin sensitivity. So increased index of the insulin sensitivity following tricyclic antidepressants, decreased BMI, total fat mass, HbA1c, and improved self-care with bupropion, and reduced depression severity predicted HbA1c in both acute and maintenance phases with bupropion treatment. There are drug-drug and other interactions, especially in the CYP34A and the CYP2C9, like fluoxetine and fluoxamine inhibition, and pioglitazide, repaglinide, and netaglinide inhibition. Whereas in CYP2C9, there is fluoxetine, fluoxamine, and sertraline inhibition, and glymepiridine. Diagnosing depression and diabetes mellitus, there is an inclusive approach, but there can be a problem of overdiagnosing. There is an exclusive approach where problem of underdiagnosing can be there. Etiological approach may not be possible many times. So substitutional approach or anticots criteria may apply. Another important antidepressant drug which nowadays is being prescribed a lot is mirtazapine. Though it has got a good effect on as an antidepressant drug, it has got a lot of weight gain, sedation, and increased appetite, and therefore one should be careful when prescribing in depressed people with diabetes mellitus. The second disorders are anxiety disorders. The prevalence of anxiety disorders among patients with diabetes is considerably higher compared to general population. Anxiety symptoms have been found to be significant risk factors for development of diabetes. And the relation of anxiety disorders and diabetes has not been explored as systematically and extensively as that of depression and diabetes. Anxiety in the context of diabetes has been studied mostly in association with depression. And mostly depression and anxiety would coexist. Now here, needle and injection phobia and phobia of hypoglycemic episodes are two conditions associated with diabetes. Patients with these conditions are likely to miss glucose monitoring or even insulin dose administration in severe cases. Also, they might maintain a state of chronic hyperglycemia for the fear of developing a hypoglycemic episode. Clinical features such as sweating, anxiety, tremor, tachycardia, and confusion are shared by both hypoglycemic episodes and anxiety disorders. This could present a diagnostic challenge, especially among individuals having phobia of hypoglycemic episodes. Chronically, anxious individuals may be more likely either to fail to pursue the initial warning signs of hypoglycemia or to confuse this with anxiety. Schizophrenia and other psychotic disorders. Association of psychotic disorders, including schizophrenia and diabetes, has been established. Overall risk of type 2 diabetes in people with schizophrenia is between 2 and 4 times that in general population. Family history of type 2 diabetes is significantly higher even among the first degree relatives of patients of schizophrenia. It has been shown that people with diabetes and schizophrenia have higher mortality rates than individuals with diabetes alone. Additionally, the presence of type 2 diabetes is associated with increased mortality risk in patients with schizophrenia. Schizophrenia is associated with impaired glucose tolerance and resistance. The prevalence of impaired glucose tolerance in people with schizophrenia may be as high as 30% depending upon age. The likely contributors to increased risk of diabetes in schizophrenia include both genetic and environmental factors, physical inactivity, poor diet, poor healthcare, and treatment with antipsychotic medications. There are some preliminary reports that suggest that schizophrenia is an independent risk factor for diabetes. Moreover, schizophrenia is associated with a treatment non-adherence rate to the tune of 50%. This has significant management implications for such individuals. Psychotropic induced metabolic syndrome is the newer generation antipsychotics gift to general population. Though they are quite effective in treating, it is very important to understand the risk associated with their adverse event in the form of metabolic syndrome, especially the drugs like clozapine, quetiapine, olanzapine. They have a serious issue with weight gain. Risperidone has a limited issue, and when there is a serious issue, we try to shift them from those drugs to aripiprazole and ziprasidone, which are weight neutral drugs. So here is the degree of risk: high risk with clozapine and olanzapine, moderate risk with quetiapine, risperidone, and phenothiazines, low risk with high potency first generation antipsychotics, and minimal risk with aripiprazole, amisulpride, brexpiprazole, which is not available yet, cariprazine, escenapine, lurasidone, and ziprasidone. Diagnosing diabetes in patients suffering from psychiatric illness again is a challenge. Psychosis itself increased risk for diabetes, increased mortality risk, decreased medication compliance. The mechanism involved in development of antipsychotic related diabetes are unclear but may include 5-HT2A or 5-HT2C antagonism, increased plasma lipids, weight gain, and leptin resistance. Insulin resistance may occur in the absence of weight gain. First generation antipsychotics increased risk. Second generation antipsychotics they are also seriously increasing the risk. And oral glucose tolerance test is most sensitive in detecting patients with impaired glucose homeostasis. A simple history of having or a family history of diabetes would suggest that we should not start with those drugs which are going to are pro-diabetogenic. There is a lot of influence of poor glycemic control on cognition and memory in diabetes. Sub-study of the action of to control cardiovascular risk in diabetes, the Accord trial shows that 20% of patients found to have undetected cognitive impairment at baseline, no difference in DSST score at 40 months, greater mean total brain volume of MRI on intensive than standard treatment. So baseline cognitive function significantly associated with risk of severe hypoglycemia. Screening for diabetes patients are screened for adenopathy, neuropathy, microalbuminuria, peripheral arterial or cardiovascular diseases if symptomatic, and cognitive impairment or dementia is often undiagnosed. Perceived lack of benefit of early diagnosis, which is a perception. Benefits of timely detection, potential benefits of timely detection of dementia and or diabetes, maximize function. Early treatment care can be instituted, greater independence, improved health and quality related life, and better clinical management and reduced healthcare cost and carer burden. It's very important to understand the carer burden in our Indian perspective. Diagnosis of diabetes in patients with dementia indicates a need to reconsider aims of care and glucose targets, an indicator to review adherence to diabetes treatment and assess nutritional status, a reminder to undertake a cardiovascular risk assessment, a prompt to review hypoglycemic risk. So these are the potential mediators of cognitive impairment with type 2 diabetes mellitus like genetic predisposition, cerebrovascular, microvascular disease, dyslipidemia, HB axis regulation, acute hyperglycemia, advanced glycation and end products, depression, inflammatory mediators, recurrent hypoglycemia, drug therapy, hyperinsulinemia, amyloid deposition, hypertension, rheological factors, macrovascular disease. And in my clinical practice, I have seen that there are a lot of patients with cognitive impairment who either forget to take the drug for diabetes or over medicate themselves. And there are frequent attacks of hypoglycemia and hyperglycemia. And this also leads to the brain damage, which can contribute to more cognitive impairment. So these are the mechanisms that may link diabetes and dementia. Comorbidity, medication, diabetes, hypertension, obesity, and dyslipidemia is the metabolic syndrome, the genetic predisposition to it. And the mediatic mechanisms would be the microvascular disease like brain infarcts, microvascular disease like ischemia, functional hyperemia, hyperglycemia, advanced protein glycation, mitochondrial dysfunction, oxidative stress, and insulin resistance. All of these would contribute to the brain pathology, and that can cause either vascular dementia or mixed type of dementia or Alzheimer's dementia. Potential role of insulin in pathogenesis of dementia. As you can see that the source of cerebral insulin, we have seen aging, which reduces insulin receptor sensitivity, reduces insulin receptor signaling, reduces insulin degrading enzyme, and Alzheimer's disease versus elderly control, you can see that there is increased insulin receptor, decreased insulin receptor signaling, and decreased insulin degrading enzyme. So the cognitive impairment affects management of diabetes and treatment related complications because of less involvement of diabetes self-care and monitoring, increased likelihood of severe hypoglycemia, increased risk of major cardiovascular events and cerebrovascular events, increased risk of injurious falls, efficient screening tools, and to establish whether early detection can improve long-term outcomes should be the goal of diagnosing dementia early. The cognitive trajectories in type 2 diabetes mellitus would be modest decline in cognition over time, even in people without dementia. This affects verbal memory, information processing speed, attention, and executive function. Modest decrements affect all age groups and are slowly progressive over time. These are not early manifestations of dementia. Dementia only affects a subset, possible added effect of Alzheimer's or severe cerebrovascular disease. Predictors of cognitive impairment, dementia in older people with diabetes. Surviving participants of the fermental diabetes study who were aged 70 years, of the 302 participants, 28, that is 9.3%, had dementia, 16 with probable Alzheimer's disease, and 60, 19.9%, had cognitive impairment without dementia. The major independent longitudinal predictors of dementia were older age, diabetes duration. For 5 years, odds ratio was 1.69 for each 5 years. Peripheral arterial disease odds ratio is 5.35. Exercise, which was protective, odds ratio is 0.26. All Alzheimer's disease, diabetes duration was an independent predictor in addition to age and diastolic blood pressure. This is a mini cog, a quick screen for significant cognitive impairment in people with diabetes. We can do this in our clinic. A mini cog is a simple test where you give or ask the patient to repeat three unrelated words, say like apple, table, penny, and remember them. So that's a three-item recall. Then you ask the patient to draw a clock of face, or you can draw a clock of face, and then you can ask him to put numbers in it so that it looks like a wall clock. And then you can ask him to set a time at 5 minutes to 3. Now, this is a task which is given to him. And after that task is completed, he is requested to recall the three words from step 1. Now, depends on how many words he can recall. If he can recall all three words, he is usually not demented. If he cannot recall all three words, he is usually demented. If he can recall only 1 to 2 words, then he can be demented or not demented, but he needs further follow-up. So in a general practice study of older people, type 2 diabetes mellitus, minicog had sensitivity of 86%, specificity of 91%, positive predictive value of 54%, and negative predictive value of 98% for dementia. And it is not influenced by education, culture, or language. Such a simple test, not even taking 5 minutes in practice, would be very helpful to predict. And if we can predict some dementia or prodrome of dementia, then we can start treating the patient on time. That is what is achieving best clinical practice in dementia care setting or in a diabetes care setting. What is advisable is in dementia care setting, step 1, symptom awareness and active screening. Step 2, symptom alleviation and complication screening. Consult with diabetes team to start diabetes treatment to alleviate physical symptoms. Screen for complications in the eyes, feet, kidneys, etc. and repeat biannually. Step 3, risk minimization. Prevent complications that will reduce quality of life. Reduce falls and hypoglycemia risk. Medicines review is regularly required and promote good nutrition. In a diabetes care setting, step 1, awareness and screening for dementia. Screen for cognitive impairment, dementia if risk factors present or patient carer concern. You can do an MMSE or a mini cog. Step 2 is MMSE is a mini mental status examination. Step 2 is manage cognitive deficit. Ensure self-management deficits are addressed. Eliminate diabetes symptoms and or concurrent infections that may exacerbate confusional states. Step 3 is minimize therapy risk. Avoid overly intensive management use therapies that reduce risk of hypoglycemia. So this is what is required when we are treating from early stage of dementia to advanced dementia. Usually history should be quoted in the beginning, but here it is quoted in the end that Sir Henry Maudsley commented that diabetes is a disease which often shows itself in families in which insanity prevails. In the Pathology of Mind, published in 1879, almost 150 years ago, this was published. And the significance of this statement is where both the things are coexisting. So that is where lies the significance of this statement. Coming to the last slide. Concluding remarks. Uh, for a healthy society, it is important to prevent, identify, and treat the health problems. However, the WHO warns us that there is a substantial gap between the burden caused by mental disorders and the resources available to prevent and treat them. It is estimated that 4 out of 5 people with serious mental disorders living in low and middle income countries do not receive the mental health services that they need. In diabetic patients, depression remains underdiagnosed, and an important aspect for diabetic specialists would be the awareness of this quite common comorbidity. A multidisciplinary approach of the diabetic patient would help improve the outcomes of disease, decrease the number of daily activity livings, and even mortality. Thank you very much.
Thank you, sir. So we have questions lined up. I am just reading out the questions, sir. The first question is, as a diabetologist, what are the steps to be taken to diagnose depression if I suspect depression in my diabetes patient?
Actually, as Dr. Sandip Shah has already outlined that we have to be very, very keen on this aspect of diabetes. We have to read about it. We have to be aware about of it because unless we are aware, we will not be able to diagnose. And the patient's behavior, the patient's if we talk to the patients, the way they talk, if you give some leading questions, like Dr. Sandeep already has said, you can get a fair amount of idea that these patients may be having depression. And then you have to administer the questionnaire. And if five symptoms are present of the questionnaire, that is the DSM criteria, and then there's several questionnaires, then you are pretty sure that this patient is having depression. And if the patient is in major depression, then you can clinically make the diagnosis very well. Like patient is having total disinterest in all the activities which he used to do earlier, suicidal tendencies, severely pessimistic approach which has developed recently. So all those things, while during talking to patients, you can very well make out basically. And a questionnaire will stand the issue wherever there is doubt. So if Dr. Sandeep has anything to add to it, I'd be happy that he should also speak on this.
Yeah, I mean, when we are diagnosing depression in patients suffering from diabetes, yes, it is very important to use screening tools, identify depression, counsel the patient especially about the effect of antidepressants, which usually would come after a lag period of say 2 or 3 weeks, because that is the time then most important support is required to them. So we have to counsel both the patients and the relatives about the time lapse which will go before the antidepressants will start acting, and choosing the antidepressant wisely in consultation with your psychiatrist or with the family physician, whoever is an expert in it, would help, so that we don't add to the pill burden, because it is very important that usual compliance studies have found that 3 pills 3 times a day would be the best for good adherence to treatment. Once we add pill burden above this, the compliance goes on declining. So that's also very important to keep in mind.
I see many physicians using very odd therapies for depression, venlafaxine, this and that. So or whatever are the simpler therapies, but using very, very complex therapies is something which is not warranted. Am I audible?
Now, sir, you're audible. In between,
Uh,
you.
so, so what I was telling Sandeep was that a lot of physicians are using very complex therapies basically for like venlafaxine and certain newer drugs as promoted by the companies basically. So what I feel that the physician should be using very, very simple and time-tested therapies which they are comfortable with. As far as treating mild depression is concerned, because a lot of patients will not agree to meet a psychiatrist. So what is your take on it, Sandeep?
No, no, I agree. You are very right that when, as a family physician, one is prescribing, diagnosing depression and prescribing, it's very important to write a very simple, time-tested, and easy to prescribe antidepressants. And usually from the SSRI group, fluoxetine and escitalopram are one of the commonly prescribed drugs. Fluoxetine and sertraline earlier were the most commonly prescribed drugs, but fluoxetine and sertraline, the common side effects like appetite disturbance, some restlessness in the initial period, we should keep in mind. Sertraline sometimes has diarrhea, which is difficult to diagnose, so that we should keep in mind. So escitalopram nowadays is one of the easiest drug to prescribe, and we can very well give a fair trial of 10 to 15 milligrams of escitalopram for 3 4 weeks, and usually the patient would respond as far as the antidepressant effect is concerned.
So the second question is choice of anti-diabetes drug in obese diabetes with dementia.
Now, if a patient is demented, then we are pretty sure that we do not want to give any complex therapy to this patient or a therapy which is likely to cause hypoglycemia in this patient. And if the patient is obese, then the therapies available to us would be one is you can safely use metformin. We can use SGLT2 inhibitors also, but a patient of dementia may not complain of UTI or local infections. So if it is a very mild dementia where the self-care of the patient is not impaired, there we can go ahead with this medication. DPP4 is anybody's choice. Basically, you can use it in practically every condition as the most well tolerable drug. And practically no issues in using DPP4 inhibitors, although they are weight neutral. The fourth class of medications which can be used is GLP-1 receptor agonist, which also can be used easily in patients with dementia. And as you know, in the long run, they are shown to be having good effects on the primary and the secondary prevention of atherosclerotic cardiovascular disease, which is one of the causes of vascular dementia. There also it has a good effect. So metformin, SGLT2 inhibitors in very specific patients, the DPP4 inhibitors, and GLP-1 receptor agonist. Regarding the sulfonylureas, we have to be very practical. We have to either avoid using it or go for low doses of it because they are very prone to cause hypoglycemia, which may be very severe.
Sir, we can't hear you. There is
If
some
it
network
goes
drop
into
at your
severe
end.
hypoglycemia and bulimia and should be less preferred in these patients. I'll just put off my video. So the voice is coming.
Yes, sir.
Yes, sir,
Acha.
audible.
So basically, the medications most preferred in these patients would be metformin, the DPP4 inhibitors, the GLP-1 receptor agonist in patients who can self care for themselves. And in this specific group, we can also go ahead with SGLT inhibitors. Regarding sulfonylureas and insulins, we have to be very particular because these drugs can cause hypoglycemia, which is very detrimental to these patients basically. So all those drugs which do not cause hypoglycemia and weight gain can be safely used, and sulfonylureas and insulin to be used with extreme caution. And if at all insulin is to be used, then basal insulin will be preferred because they cause less weight gain and they cause less hypoglycemia.
So the next question is, can you please repeat the drugs name that may induce metabolic disorder in psychiatry? Psychiatric drugs, they are asking, doctor is asking which are the psychiatric drug which may induce metabolic disorder.
So the most commonly cited drugs for metabolic syndrome or metabolic disorder would be clozapine, which is second generation gold standard antipsychotic used in schizophrenia. And the other two commonest drugs are olanzapine and sometimes quetiapine and risperidone to a certain extent. But most commonly you see is olanzapine and clozapine, which would be responsible for metabolic syndrome because they cause hyperglycemia, they cause hyperlipidemia, they cause weight gain to the extent of almost 3 to 6 kgs every year. So these are the two drugs which are responsible.
The next question is, what would you recommend a person with type 1 diabetes to cope with stress, specifically pertaining to living with this chronic condition?
So when we are
Basically,
talking, sorry, when we
no,
are
no,
talking of
certainly go
a
ahead.
condition which is going to be there lifelong, we have to ask and train the person to handle the stress, make it part of his life, and how that is to be done, that should be taught to the person by regular counseling and regular exercises which would help him build resilience against the stress that is going to develop. Over a period of time, he starts and learns to live with that illness or that problem as part of his own body, and he accepts it, and then he has less problems because of that. And it's very
Uh,
important question because if we cannot handle or do not handle the stress, it again is going to have some adverse effect on the existing diabetes, and he may need more treatment. Yes, Dr. Akash.
Another important aspect of managing psychological disorders in type 1 diabetes is that majority of these patients are pretty young or children basically. So managing their family, training their family, educating their family to handle their children and to provide a very healthy atmosphere and to boost morale because if the family members are not trained enough, not educated enough to handle type 1 diabetes and to educate their child. So a education of the family, even this at the school level also the education of the teachers because what I've seen is that the teachers at the school if they detect that patient has that child has some serious disorders, they avoid that child, they discourage that child, and they feel that why I should handle this unnecessary burden. So at the school level, at the family level, there has to be important education provided regarding this disease, and they should be trained to motivate the child to handle the child in a proper fashion so that the child is motivated and he learns to handle his disease in a better fashion.
So the next question is, what are the early sign of a diabetic coma?
No, there is nothing like early signs of diabetic coma. Basically, what happens is that a patient of diabetic coma may have either hyperosmolar coma or a diabetic ketoacidosis induced coma. Now, more common is the hyperosmolar coma, which occurs in the elderly population, which basically is in an insulopenic state. There is not a complete insulin deficiency, but a relative insulin deficiency, and these elderly are generally neglected population. Is very less commonly seen, and what happens is that the blood sugar levels go up, and there is a hyperviscosity building in the blood. And when the blood sugar levels shoot up very much, basically, then this condition sets in, and patients start behaving abnormally. There is confusion, there is altered behavior, and if this is not recognized in time, then the patient will lapse into coma. So this basically is a clinical diagnosis. The second is the decay, basically, where there is hyper the because of the excessive blood sugar levels, there is excessive urination, there is severe dehydration, there is a development of acidosis, and all these leads to impairment of the brain functioning, leading to anxiety, distress, and then subsequent coma if you not recognize early. So all this recognition is in the setting of history of diabetes is a clinical judgment. Basically, you have to see the patient, take clinical judgment, do the investigations, and then you can diagnose this condition. This is not a condition which you can diagnose without the clinical parameters being seen or without a proper history, proper diagnosis, and proper clinical examination.
So the next question is, if you could give a person with diabetes three pieces of advice to avoid stress pertaining to their condition, what would they be?
The three pieces of advice which I would give to my patient is one is to have regular exercise because exercise I feel is a major antidepressant. The second is to avoid those kinds of jobs which basically have more work and less time. So more work and less time, higher targets and the time being less. So all this, if the working atmosphere is not good, then there is likely to be stress. And third leads to in the family also to have a good interpersonal relationship and not to avoid into unnecessary conflicts and fights with the family people. But all having said this, it is not always easy basically to get into this basically. But these are the advices: a regular lifestyle with exercise, avoidance of stress at work and avoidance of stress at home, these three are followed, then I think this incidence of stress-induced disorders will be pretty less. They also have to accept their diabetes and manage it in a positive fashion.
Uh, Sir, then there is a question: how do you see age factor for mental illness of a diabetes patient?
See, with aging, certain changes are bound to set in because the patient with long-standing diabetes has, as it is a older population, has atherosclerosis and there will be multiple infarcts because of blockage of the small vessels. And diabetes will lead to exacerbation of this condition. So, more chances of multi infarcts and dementia. Second thing is that if the diabetic elderly is basically not having good hobbies or not having good friend circle, not moving out of house, then he is likely to get into this depression and dementia part. So he should have inculcate good hobbies. He should have good friends. He should be reading good books. He should have good interest in life. The third most important thing is that he should concentrate on regular exercises. And in old ages, the flexibility and the balance exercises are one of the key exercises which we add to the regular routine exercises. So, if all this is followed, basically, then there will be less chances of depression and dementia. What we've seen a lot of elderly people stay at home, don't move out of home, so staying at a place basically with no entertainment, no change of atmosphere will lead to more chances of dementia. So independence is a key factor in the elderly if they want to avoid into getting into depression and dementia. Dr. Sandip, please give the major uh, things to add.
Yeah, Dr. Akash, I think you have very well narrated what would be a good advice to patients and what would happen with aging and diabetes. Definitely, dementia being a disorder of the senile age, it is very important that lifestyle functioning has to be well. And therefore, if we can tell everyone to have a regular lifestyle, find time for their own selves. I sometimes nowadays also give them an example of how they have been able to cope with living at home during the corona times and how they have used that time so that there is positivity in everything which you are doing and that will help them cope with the problems. Go ahead, Sarbani.
The next question is: which are the safest antidepressant drug to start with for a diabetes patient?
Yeah, so as I told, the SSRIs would be the safest drugs to start with in diabetic patients, and escitalopram, sertraline, fluoxetine in that sequence can be preferred for as an antidepressant in diabetic patients.
And another question is: what are the effect of mental health for diabetes patient? Do diabetes patient have mental health issue? And what are the general common mental health issue that a diabetes patient face?
So yes,
Basically,
diabetic patients will definitely face issues like he has been diagnosed with diabetes and how he's going to handle them, and the anxiety is he's pursued information and pursued uh, problems, or the he feels that something very wrong has happened with him and now how he's going to live. That is very important, and therefore that is the time when he is newly diagnosed that we try and give adequate input, give adequate input through patient information booklets, information videos. So much of training can be done for him, and that will help him understand the illness, take care of what is required to be done regularly rather than being scared of the illness, to take care of being glycemic control should be normal and how that is going to help him. You can add, Dr. Akash.
as I already outlined, basically the diabetic patients may have diabetic distress, which we had discussed, then anxiety and associated anxiety conditions. Then patients may have eating disorders, bulimia, binge eating. Patients can have depression and other associated conditions and more chances of dementia. So all this is a spectrum of mental diseases that a diabetic population is more likely to suffer.
Sir, we have come to the end of the questions, so there are no questions anymore. So, sir, on this note, I would like to thank both the eminent speakers. In a very wonderful way, you have made us understand the aspect of diabetes and the effect on mental health. And the question answer session has been very lively, and many questions has been posted. So, we understand the participants have enjoyed and learned from this interactive session. And I would also like to thank all the doctors who have logged in for this session. And I hope that this session has been helpful for them also.
Thank you,
So, sir,
Sarah.
on behalf of Lupin, thank you all. Thank you, Dr. Sandip Shah and Dr. Akash Kumar Singh, sir. Sir, can we then conclude the session then?
Absolutely, we can do. I thank Lupin for arranging this wonderful seminar on awareness of mental disorders and diabetes. I thank Dr. Sandeep Shah for accepting my invitation to join in and deliver this wonderful lecture. I thank all the doctors who attended this session and made this session a successful event. And with this, I think we should conclude the session because we are already over time.
Thank you, sir. Thank you. So, sir,
Thank you.
with due permission with both of you, sir, I am concluding the session officially. Thank you.
Thank you.
Okay. Thanks.
Okay. Thank you, sir.